Hey peeps, today we're going to talk about cancer and pregnancy. A lot of these videos are made by me for me so that I can have a quick reference in the future when I want to go back and look at the literature, and I've compiled it all here. So I hope you find some benefit and learn some things from these videos. So we'll start with cervix and then we'll go to ovary. All right, so diagnosis. Depending on whether or not you're a benign gynecologist or gyn-onc, your diagnosis most of the time will come from a colposcopy, especially in pregnancy. Colposcopy is safe and it needs to be done. You need to have a tissue diagnosis, but no ECC, so no endocervical curettage in pregnancy. And you'll see when we go over the recommendations for treatment, you can do a LEEP or a cone, CKC cold knife cone, if cancer cannot be excluded with a smaller biopsy. You do have to talk to your patient about the risks of a LEEP or a cone, including the risks of preterm birth and other complications. When you're working on a diagnosis, obviously you want to avoid any radiation in pregnancy. So you want to avoid an abdominal x-ray, you want to avoid CTs, and you also want to avoid PET scans. You can consider a chest x-ray with an abdominal shield, but your mainstays are going to be ultrasound or MRI. And if using an MRI, you do want to make sure that you stay without gadolinium. The gadolinium can cause a possible increase in rheumatologic or dermatologic conditions and potentially increase the risk of stillbirth. So this is the main algorithm that we will be using throughout this presentation, at least for the cervix part. And it kind of goes through the major questions you want to ask. So I think the number one question to ask yourself and your patient is the pregnancy desired? And then yes or no based off of that. So we'll say for the purposes of this presentation that pregnancy is desired. And then you break it down to less than 22 weeks or greater than 22 weeks. So let's go through the greater than 22 weeks gestation algorithm here. Okay, so starting with cervical cancer less than 22 weeks, stage 1A with no LVSI is just like non-pregnant patients, cold knife cone. You will obviously talk to the patient about the risk of bleeding, a risk of spontaneous abortion. And then stage 1A1 with LVSI, 1A2 through 1B1. These patients, a staging lymphadenectomy should be performed as a first step, and this can be done up to 22 weeks gestational age. And then you can either do a larger cone or a simple trachelectomy. In stage 1B2, there are two options. So a pelvic lymphadenectomy followed by chemo or follow-up. And then the second option is neoadjuvant chemotherapy, and then you can do subsequent surgical staging after the tumor has shrunk with neoadjuvant chemotherapy. If the nodes are positive, the paper that I'm basing a lot of this information off of, which I will reference at the end, recommends termination of pregnancy. But then they also state that if patients do not desire termination of pregnancy, that chemotherapy could be considered. And then for stage 1B3, the only pregnancy-preserving option is neoadjuvant chemotherapy. And then stage 2B or above usually recommend termination. The neoadjuvant chemotherapy that you'll be using is carboplatin and paclitaxel. The ideal window is from 14 to 35 weeks. It is contraindicated in the first trimester due to organogenesis. There's an increased risk of IUGR, PPROM, and preterm labor with chemotherapy, and a risk of congenital malformations around 6 to 16%, but less later in gestation. The chemotherapy ideally would be discontinued 3 weeks prior to planned delivery, and that is to allow for bone marrow recovery, and then so that counts are fine. Okay, now let's go to greater than 22 weeks. If it's an early stage, stage 1A to 1B1, you will want to delay treatment until 6 to 8 weeks after delivery. And while you're delaying treatment and, checking on the patient, they come back for their prenatal visits, you'll want to do an exam every 3 to 4 weeks just to be sure things aren't progressing, at least to your eye. And as we said earlier, chemotherapy is contraindicated in the first trimester. You want to end 3 weeks prior to delivery. No anti-VEGF agents. I know you know this, but that's bevacizumab. And then just a few notes that I left for myself down here that paclitaxel is supported by evidence to be safe in the second and third trimesters. Carboplatin is preferred for GYN malignancies other than germ cell cancers. So in cervix, even though mainstay cervix not in pregnancy is cisplatin, we'll use carboplatin here, mainly because cisplatin carries the risk of ototoxicity in children who were exposed in pregnancy. And then this is just another diagram from a really nice paper from the Annals of Oncology that goes through kind of exactly what we had previously said here, just a different way. And here are my references. I would strongly encourage you to read both that first paper with the PubMed ID 3143, blah, 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 and then the second one, the Annals of Oncology paper. They're both excellent. Up to Date is always a really nice source. It kind of breaks things down into more simple terms. And then there is a GYO-EDU video, I believe, about cancer and pregnancy as well. So I hope this was helpful. Consider it a part 1, and we'll do ovarian next.